The Aquila study is intended for patients with smoldering and multiple myeloma. That means myeloma that has not yet symptoms yet, of high risk. That means that they are expected to have symptoms in the following 3 years. So, and it's comparing the standard of care, which is just observation and waiting until symptoms or criteria to treat myeloma appear, and daratumumab for 3 years.
We know that there is an increasing number of patients with myeloma that are being diagnosed by chance without any symptoms. We call these patients asymptomatic or smoldering myeloma. This is a heterogeneous group. Many of these patients will have a very low rate of progression and they will resemble more like MGUS. However, there is a subset of patients that has some features which may predict that the risk of progression is higher and the progression may occur sooner. For these particular patients with high-risk smoldering myeloma, we would like to have a therapy which is well tolerated that will delay progression and furthermore to prevent the development of skeletal lesions, fractures, renal impairment, severe anemia, and other end organ tissue damage. The efficacy of the study was evaluated by assessing progression-free survival to symptomatic myeloma, and we saw that the administration of daratumumab was able to reduce the probability of progression or death by 50%. So this was a very important clinical measure and also statistically significant. Furthermore, we saw that patients who received daratumumab had a longer probability of survival versus those who did not.
Daratumumab alone as monotherapy has a very safe profile in terms of safety. There's no safety issues. So those patients that start with weekly daratumumab but then end up with monthly daratumumab have very little side effects. So the treatment is very safe.
I believe that these data are practice-changing, indicating that if the results of this study are being evaluated by regulatory authorities and approved, that means that many patients with high-risk smoldering myeloma may benefit from treatment with single-agent daratumumab. Because daratumumab is being given only for 3 years, if the patient progresses after discontinuation of daratumumab, especially several months or years after, then re-challenge with daratumumab could be given. Of course, if the patient progresses while on daratumumab, then another treatment should be chosen.
The progression after the next line of therapy is still better for those patients that did daratumumab before than those patients that were only observed. So in theory, those patients only with observation have more options because they have not been treated yet, while the others have less options because they have already exhausted daratumumab. But in practice, you don't see that this is deleterious for the patients that were with daratumumab.
This study has to be evaluated by FDA and EMA, and if approved, then it could be adopted by European countries and the United States and other countries, and then reimbursed and then be available for our patients.